Welcome to the Pivotal Podcast. Today we're joined by Dr. Carolyn Harmon, past president of the American Nursing Informatics Association and professor and director of healthcare leadership, nursing informatics, and nursing education at the University of South Carolina. In this episode, we'll explore Carolyn's career journey, her contributions to healthcare informatics, her role in leading educational initiatives, and her insights into the evolving landscape of health technology. Carolyn, thank you so much for joining me today.
Oh, you're very welcome.
Yeah, I am super excited about having this conversation and just all of your different areas of experience and what you're bringing to the table this morning. So I know anybody listening is going to get a ton out of this. So I'm just going to go ahead and dive right in where I like to at the beginning and just ask, tell me what initially drew you to nursing? And then with that, like, how did your passion for technology influence your career path that's brought you to where you're at today?
So I originally was not even interested when I was growing up in healthcare at all. But when I was around 15, 16 years old, I was very close to my grandfather, and he actually passed away from a sentinel event, which is where people make a medical mistake. And I was always interested in numbers and business and science, all of these different things that kind of go along with healthcare and healthcare practices. And through my observation and experience, I really thought, I could make a difference in people's lives and hopefully impact other situations to where another family did not have this negative experience. And that's what drew me into healthcare and becoming a nurse. And I've been a nurse for many, many years. I graduated at the age of 19, but I passed my boards when I was 20. And then as time went by, I was at the bedside approximately about a decade, but I started working on my master's in nursing, which had a focus of health systems management. And through that focus and that degree, I actually was exposed to informatics, because in those earlier days of my career, informatics wasn't even a commonly used terminology in healthcare or healthcare practices. It's kind of one of your newer specialties in nursing. And I did have the privilege of taking a course from one of the founding and navigating individuals in nursing informatics, which was Dr. Sheila Engelbart. And she wrote one of the very first informatics textbooks. And that's when I really started thinking, this is where I want to go, because quality and data and all of those things were really interesting to me, plus the innovation of the technology that you add into informatics. It just really excited me for what I could do. And shortly after I graduated, I had the opportunity through my mentor in my master's degree to work for her. And she was one of those individuals that really was inspiring, where she had great expectations. And some people have challenges working for an individual like that, but I actually do better when I work for an individual that has great expectations of me and they want me to go forward and do great things. And although that's kind of stressful, because you want to please and you want to meet those expectations, but what she did is she knew what I had an interest in, and she tried to navigate my career pathway in that manner. So over probably the next decade, through her support and assistance and other people that in my profession and my professional experience and connections and network, I was able to navigate a path of informatics, quality, leadership, and really I felt like I made a huge difference in the populations that I managed during those days. So that's how I kind of I just kind of fell into it. And I think a lot of people that have become informatics nurse specialists or just started working in informatics is because we fell into it, because it's been this pathway that's unique and newer, and it's a newer specialty. And so I think that that's kind of like a similar story to probably others.
Yeah, I hear that a lot. Everybody says like, "Well, I didn't start out with this in mind. It wasn't my end goal. I fell into this." I hear that language a lot. I fell into this. So I think it's really interesting because as it evolves, I think the goal is, once things get more clearly defined, maybe to make it an opportunity people know about so they can actively choose it rather than falling into it, right? Because not everyone's going to get lucky, but if we can have some, and granted, like, circumstances definitely shape our pathway, right? But if we can have some intentionality behind it, it's another option that people could choose, and it's a great option. So if more people know about it first off, and then know about how to get into it, they can make circumstance and other external factors, right? So I think it's really worthwhile exploring these journeys. Like, okay, well, how did you fall into it? How did you find it? And then, okay, maybe we can lean on that. Another common thread I hear so often in these conversations is a mentor. A mentor helped me. They recognized potential in me that maybe I didn't even recognize in myself. They challenged me. They pushed me. And then, I was saying yes to things, and one thing led to another, and here I am. So that's awesome. So when you started out in nursing, what area of nursing were you in?
So I've done all kinds of clinical nursing. So I have worked in med surg, telemetry, coronary care, but I worked the majority of my career either in the emergency department or open heart recovery. And both of those areas I really, really loved. I feel like the emergency department has been something have gone back to as I've advanced my career, because I have an interest in cognitive load and how technology, if there are connections between a person's cognitive load and technology. And I think that I like to study the emergency department population because they have the most distractions. Now, I do still have the love with open heart because and this is probably going to sound a little bit crazy, but I really do like the things that we did when I worked in downtown Charlotte. We were able to just crack somebody's chest open and save their life, and you do have to have a certain kind of stomach for those kind of things. But it is, once you have that adrenaline and the ability to do these things, and you see the outcomes of saving those lives, and you're working in a high functioning professional care team, that it's amazing at the end of something like that, how good you can feel when you save a life.
Oh, it's incredible. And I have so much appreciation and respect for people like you who can do that, because I love adrenaline, and I thought I wanted to go to medicine. And then when I shadowed doctors, I found really quickly, I was 17 years old watching a thoracotomy. And I got super sick just watching it happen through a window, even, like, okay, this is not for me. So the fact that you can do that, it's like there are people that are wired that way for a reason, because we need it, right? That's amazing. And then I love what you're saying about cognitive load as well, especially in the emergency department, because it's fast paced. You've got a lot going on.
Yeah.
You can't, let's see, how would I say this? It's not going to work out if you're distracted, right? Like, a distraction, being overloaded cognitively, that's going to possibly cause an accident or some sort of miss or some kind of catastrophic consequences, right? Because you're dealing with high paced, like high pressure, fast paced emergency types of things. So this is, I don't know, we might wander around a little bit, but help me understand. I feel like the goal of software is to reduce that cognitive load so that people can focus on providing care, right? But is that the reality? Is that what we experience there? How does software contribute, or EMR, or informatics? How does that contribute to cognitive load, especially like in the emergency department?
So the intention of technology originally, when especially the smarter the technology, and some of the earlier days like meaningful use and those areas, the intention was for what's called clinical decision support. And that clinical decision support is supposed to remove barriers or kind of be supportive to identify areas that we may miss as human beings, such as there was this one product that one of the EHRs during the implementation, it was called Sepsis Crawler, and it would crawl the back end of the EHR and it would identify those small, tiny little changes in people's lab work and various other little things that we may or may not just see those small changes over time, but it would identify that and then alert the physician and nurse and say, hey, is this person possibly, have they gone into sepsis? So it was an early identification of sepsis, and it was to support that care team in something that they may or may not identify. So the intention of things like that was to reduce the workload, ease the decision making of the care team. However, what we have seen is actually the exact opposite. We have in healthcare, unfortunately, we are heavily regulated, and we also have accrediting bodies. So we have two bodies. You have regulatory and accreditation, and then you have your payers that you're trying to meet all the needs of all of these entities that are external to healthcare. And what happens is a lot of times you just like start piling all of this data collection, and sometimes it's duplication, and it's really that documentation, and it's called clinical burden. And through that, we have noticed that we have really added burden, and that the care and clinicians, instead of them carrying and spending more time at the bedside with the patient, they're spending more time in the technology and using the technology, and even patient feedback has given us that. So I actually conducted a research study called Unintended Consequences of the Electronic Health Record and Cognitive Load in Emergency Department Nurses. It's, to my knowledge, it's one of the only research studies that has been that specific to emergency department nurses, and then trying to make those connections between unintended consequences of the EHR, which one of those unintended consequences is patient safety. And what I identified is actually instead of patient safety getting better over time, when I took my study that I conducted recently and I compared it to the one other early on previous studies, there's actually been 3 people that studied this, and I'm one of those. But Dr. Gebhardt and Carrington is one of the very first to study unintended consequences of the EHR in nurses. And now there's a lot of research and studies and physicians that are out there. But when you take this in nurses and my study, and you compared it to what they found, it's actually increased, and it's become worse instead of better. And so our patient safety is not where we need to be. And there are connections between cognitive load and those unintended consequences of the EHR, but it's in subgroups of the population of the emergency department as opposed to the entire population. So the AHRQ on their patient safety network, they picked up the article and said that it's my research team's article, and they have said that it's something that we need to look at, and we need to use further research, as well as we need to start. One of the recommendations that my research team has made is to have more of the end users, which is your care team, your nurses, involved in the design of the technology as well as the selection.
Right, because that makes sense, because what I've heard repeatedly recently is that nurses are the most frequent end users.
Right. They are the largest end users. So nursing is your largest subset of the care team that employed in healthcare. So therefore, they're going to be your largest group of end users of the electronic health record. So and plus they're there at the bedside with those patients 24/7. So the bedside nurse is really a major population that needs to have more research and, as opposed to people who, and I'm not trying to be negative, but physicians are there like 15 minutes with the patient, where again, the nurse is there 24/7 and using that EHR or the other technology associated with the care of that patient in that 24/7, 365. So I think that they have a little bit, broader viewpoint that they can bring to the table.
That's so interesting. So now your study identifies this correlation, right? And this decrease in patient safety and increase in cognitive load, I guess.
Mm-hmm.
Did it start to dive into causation at all? Like, what is it about this? Or what's the next step now that we know, okay, it's getting worse? How do we figure out what's causing it specifically so that we know how to start to improve it?
So when you are a researcher, what you do is you take your topic of interest that you want, or your concepts that you want to study, and you start off with doing a literature review, and through that literature review you see what others have accomplished through the research. And how you gain knowledge is through continuous and continuously having more and more research and higher levels of research. Unfortunately, because again, we kind of go back to computers are a little bit newer in healthcare, and like we discussed earlier with informatics, back in my day I fell into it. It is a little bit more intentional in today's day and age because it is a known topic, and we now have degrees associated with informatics. So we are growing and we are advancing informatics as a specialty. But because of the, I guess, it's newer in healthcare, there's not as much research as like other topics. So when you're starting out initially in doing this research, you're going to start off more on that qualitative side where you're just like gathering information. We have now transitioned. My study was quantitative. So we have transitioned, and Dr. Gebhardt and Carrington created the very first tool to do that measurement with. And so as you grow and advance, you get into the causation. So my study was just a correlation. So I think that basically we need more research. We need more informatics nurse researchers, and it's big gaps. It's big gaps in the literature.
So how long does it take to put together a study like that? And then what's the scale? I mean, how are you collecting this data? And I don't even know, like, what are the numbers we're talking here to find something statistically significant? Like how many, and I don't know what you're looking at, right? What the measures are, if it's, if you're looking at individual nurses or if it's patient records, or I don't know. Can you tell me a little bit more? Because clearly I have no idea how this works.
So actually, I mean, I have some ideas of doing more with like patient records, like you said, and digging down into more of the EHR data and big data, maybe some of that databases, and researching and studying it from that lens and that viewpoint. This particular study that that our team conducted was, it was greater than 300 nurses that responded. I think to have statistical significance, we only needed 90. Wow. If I remember correctly, it's all written in the article, the specific numbers. It did take a long time to conduct a study. It takes a long time because, first of all, to do it appropriately, you do have to go through the ethical approvals, which is your IRB. You have to do a lot of background in the beginning. Like I said, the literature search. So that takes a little bit of time. You need to gather a team together of those interested that want to work together. It shouldn't be a one person that's conducting, just because it's richer the more people you have at the table, because there's different lenses. Some people, maybe specialty is informatics, like myself and another person on the team. We were informaticists, okay, nurses. And then another person was not even a nurse. She was an epidemiologist, and where she has a skill set in heavy research, heavy big data, statistical knowledge, to help guide me through some of the statistical analysis. The other person, cognitive load, and actually she does a lot of sleep. She does a lot of sleep research, but that's where she has some cognitive load specialty as well. And then my last person was Dr. Gephardt, who created the tool, and she could give us insight as to navigating, okay, this is what went well with our study. This is what, kind of like those lessons learned, so that we can do a better study. And
common pitfalls to avoid, and absolutely.
Right. And this was a national level study, and we did recruit through the Emergency Nursing Association. And so I think that because of that, that does make the study a little bit richer, because it was a national recruitment. It was not just focused in one part of the country. We did have responses from every part of the U.S., and our response rate was high, which is unusual. But I do believe that because it was through a professional organization, that there wasn't any fear from these nurses. A lot of times, if you go through their organization where they work, nurses are fearful of responding, and also responding honestly.
Yeah. If I say the wrong thing, am I going to get in trouble or fired or whatever?
Even though there is, it's anonymous. And so with our research, it was anonymous. Unless they wanted to share their email with us, they could. They didn't have to. And not everybody did. But the reason why is we did give them, if they wanted to share their email address, we did give them a $5 Amazon coupon, so that, just as a thank you. And that was approved through the IRB, that it was appropriate. And we did have a grant from SIGMA, which is the International Nursing Honor Society, and the ENA, the Emergency Nurses Association. They had a shared grant that they gave us $6,000 to conduct a study, and that helped us be able to send our information with the QR code to the survey. We mailed that out. We were able to purchase a mailing list. It was anonymous because that list went directly to the mailing team. So the research team did not have access to those names at all. And it was mailed directly from our person who created our postcards, our publisher, and they also did the mailing. And so it was really good. I really feel strong about the evidence, and I think that it just it gives us insight, and leads us actually to more questions like what you just asked about causation. Why are we seeing this, and where can we go from here?
Yeah, for sure. So a couple interesting thoughts about this. Number one, I would speculate, and now we can't know for sure why, but I would speculate the response rate was high because it's something that the nurses want to talk about. Like, this is relevant, and somebody needs to know this. And if we can fix it, it'll make our lives better, and the way we care for our patients better. It'll make patient outcomes better. So it's worthwhile for sure. How can you tell me a little bit more about, like, how long did it take for the nurse to complete their part? And then can you give me an idea of what kinds of questions you guys were asking?
So I think it was like 20 minutes or something like that.
I mean, that's a pretty significant length of a survey for somebody to complete. They had to really care, to do this.
So it was created kind of, there was different sections of the tool. So because we wanted that bedside nurse, we, and somebody that had used the EHR for 6 months, somebody that had been employed at that institution in the emergency department for 6 months. So there was some criteria. We did not want leaders. We did not want managers. We wanted that voice, that bedside voice. And so there was like, I think 6 questions in the very beginning that was just like inclusion, exclusion, and it would give them a pop-up if they hit one of the excluding factors. We also wanted people who were part-time and full-time employed, and you could be an LPN or RN. So those first 6 questions was just basically, you know, should you complete this, should you not? Then the next 10 questions were the NASA TLX, which is a tool that's commonly used for cognitive load, and it was originally invented by NASA for pilots. Wow. For pilots and NASA. But if you look at the literature and you're going to do a subjective measurement of cognitive load, that is a commonly used tool. Now, we are trying in the research realm, we are trying to come up with more of an objective measurement, which is, you know, you can't use heart rate because you're running around in the emergency department or other places in healthcare. Nurses and physicians, all of them, you know, they tend to just run around. And so you can't really use that as a measurement because you're going to have high lows and stuff like that, especially if you're doing CPR. And it's one of the most exercise intensive things you can ever do. And then, so basically what we're looking at is dilation of the pupil for an objective. So that's something that I would like to do futuristically, something like that. But anyway, back to your question. Then first, so the next 10 questions was NASA TLX. Then I think it's 32 questions, maybe a little bit less, maybe a little bit, something along those lines, it's a Likert scale of the unintended consequences, because there is a breakdown of unintended consequences. You have patient safety. So each question is tied back either to one of the unintended consequences, like patient safety, workarounds, socio-technical. There's just a number of those unintended consequences. So it's broken down into those different concepts.
Can you give me a little bit more of a concrete example of like what's a patient safety consequence that results from a nurse that has like cognitive overload?
So this is so your tools, you have your NASA TLX, and that's your cognitive load, and that's just basically a ranking, it's a ranking of like how you felt when you were using the EHR. And like, did you feel like you were in workload overload, blah, blah, blah. Those kind of questions, where then those next 32 questions that you were using that we used for the unintended consequences, that was created by Drs. Gephardt and Carrington. It has, it's like a Likert scale of frequency. So what is the frequency of a medication concern or issue that what is your frequency of experiencing this medication concern or issue in the electronic health record? And the frequency is that we were seeing with patient safety is around weekly to monthly, and that's too frequent. I mean, that's just too frequent. Even
so let me see if I'm sorry, go ahead.
I mean, to me, that means you're seeing problems either like it's a frequency that we were getting that was between that weekly to monthly time frame, where Dr. Gephardt was seeing it like monthly to every 2 months.
Wow. Okay. So yeah. So so that's the measure. That's how you know. That's how you know it's getting worse. Yeah.
And Dr. Tolentino is the other person that he conducted a research study that was of one particular 3-hospital healthcare system, and his study was close to, it was like within a year of our research team study, and his saw a very similar frequency that ours saw, where ours was published in 2023 October, this past October, and we conducted it 21 to 22 over that time period. So we were doing data collection at the end of 21 and the beginning of 22. And Dr. Tolentino's study, I think, was published either in 21 or 22. So he did his data collection, I think, in 2020, where Doctors Carrington and Gephardt, theirs was published around 2015.
Okay, so let me ask this question.
5 to 7 year. I'm sorry.
Say that part again. I definitely interrupt you. Say that again.
So I would say 5 to 7 years, a gap where we were supposed to do what's called optimization. So during the meaningful use years, we were doing heavy implementation, and because we were given timelines from the government, so that these healthcare institutions would get their meaningful use dollars, which was in the upward range of multi-million dollars, especially for the larger healthcare systems. But you had to do rapid implementation and to meet those timelines to receive that return on your investment, which is your meaningful use dollars from the government. Okay, because of that rapid implementation, it wasn't clean, is what I call it. I would say we were doing less going back and optimizing our systems and processes and workflow for those clinicians, because we were continuing to do implementation. And I was involved in a lot of this during my clinical informatics role, doing the implementations and the training and the elbow support is what we called it, where we were there for a month on site with our clinicians during their what we called the go live or the implementation of the tool of the EHR. And but I also worked on the clinical transformation team, and this was from a different study that I had conducted. We created this clinical informatics transformation team to do a lot of optimization parallel to the implementation. So some institutions were trying to optimize, but not many were. So you end with, all right, we're at the tail end of meaningful use, and now we're supposed to be going back into this optimization phase. And instead of us seeing an improvement in patient safety concerns, we're seeing a higher frequency of nurses reporting a higher frequency of concerns. It could be related to problems in physician ordering. It could be medications. It could be workflow. It could be just a number of things. People doing workarounds because it just did not fit into their workflow. I mean, there's so many things. So that's why the tool is 32 questions. Then we ask which is unique, and our team decided to do this because we felt like the data collection for the cognitive load and the unintended consequences was so important. We front loaded those questions just in case there was survey burden, because that's what you were alluding to earlier. That's a lot of questions, Carolyn. Yeah, I felt like it was. Yes, I agree. And so then we added in questions that we felt were relevant, that we called demographic questions, like are you an RN or LPN? Are you what is your level of education? How long have you been at your institution? What is your EHR that you're using that's related back to the vendor? And so there was a number of those questions, believe it or not, because the very last question was the email address for that $5 gift card. Most of the people completed. Now, we did throw out like people who just opened it up and they did not complete. We threw all those out.
Sure.
So it was interesting that the number of people that did finish. And then because we were testing, we were doing what's called psychometric measurement, which we're testing the tools to see if there was reliability and validity of those tools. To do reliability, this is really getting into the statistics, and I hope that I'm not like losing everybody, but you have to do a test and then retest to make sure it's reliable information. We did have actually a really good response rate for that retest. So we had like a 300 and some original completion of the original survey, and then we had over 100, I think close to 200 that actually did the retest.
Wow. So of the same people.
Mm-hmm.
Wow, that's amazing.
Connect it to the same person in order to make sure you have that consistency, reliability. So you test, and then 2 weeks later you retest them.
Sure. That totally makes sense. That totally makes sense. I have two questions. One is a really obvious question for everybody else, but I don't have a healthcare background, so I have the benefit of just being like, I'm just going to ask this. Help me just really, really quickly just understand like what meaningful use is. And then I want to ask something more specifically related to the study itself.
So that goes back to legislation, and there is legislation that has meaningful use embedded into it, where it kind of goes back to what you were saying. The intentions, the original intentions were positive, and people wanted to help the care team and improve outcomes. Those were the original intentions. That's why it's called unintended consequences of the electronic health record, because the original intentions, and there are a lot of great things that have come out of this, the implementation of the electronic health record. Things are a lot better than the days that we were doing handwritten documents, because only one person could look at the medical record at a time. So that's one thing that's fantastic. You can have a physician that is outpatient looking at a record, while a physician that is inpatient looking in the hospital looking at a record, and then you can have a nurse looking at that record while he or she is at the bedside, administering medication. So there are a lot of great things. So I don't want to paint the picture that this is this horrible thing that we've done. It's just, it's imperfect. And what we can do to improve, the end result will be to improve patient care outcomes, because at the end of the day, like for instance, you're scanning the patient's armband, you scan the medication and all of those things, because you have what's called the 5 rights to make sure it's the right patient, the right drug, the right dose, all of that information to prevent a medication mistake, because medication mistake is the number one mistake that a nurse makes.
Okay. Interesting.
It's one of the most high risk. If you give, I used to be a director of quality and chief safety officer at an institution, and medications was always one of the number one things that, when I was investigating an incident, that I would see that a nurse would make. And like, for an example of that was, we had a nurse that was supposed to give a patient just a normal, it was in the emergency department, and she was supposed to give a cardiac medication. And it was just a normal to help with that person's rhythm. Wouldn't have done anything but a positive thing for that particular patient that had come with feeling chest pains, but it was the person's heart rhythm was out of rhythm. You give the medication, they usually convert. If not, sometimes you do have to do some shocking or something like that, but you try the medication first, because that's the easiest way to convert them. The nurse picked up the wrong medication, and it's called Sux, or succinylcholine, that she picked up. And it is what we use to actually stop breathing so that you can intubate a patient, put them on a ventilator, like for surgery. So, because you have to stop their breathing and put them on. So she gave them the wrong medication, and they stopped breathing. and the person arrested, and we did save the person's life, but it was all from given the wrong medication, and she did not do the scanning. So she did a workaround because she was in a hurry, and she did not scan those medications. And so if you do a workaround and you don't utilize the tools appropriately, that's an example of what can happen.
Wow. And the heart behind that was probably, I need to do this quickly and efficiently so that I can help more people. It's never to hurt somebody, right? Like, but
good
really,
intentions,
yeah,
a bad outcome.
Yeah, absolutely. Wow.
Because
Wow,
it slow you down. So that's one of the things that you get a lot of feedback. So my very first study was around what are the perceptions of acute care nurses. So I did an entire hospital, and it was, when they were going from paper documentation to the EHR, and I did a 5-year study starting with 6 months prior to any education about the electronic health record, and then 5 years after implementation. So I did it in different increments throughout those years. I surveyed them. What were their perceptions of the use of the EHR? And in the beginning, the perceptions were very positive. 6 months and 18 months after, it was negative, but 5 years they had gone back up to where they were more positive. It was not back to the baseline. It never went back to that positive baseline. But the number one feedback that I received from that survey at every increment from the 6 month to the 5 year was time.
Was paper faster, like before the EHR?
I would say from my personal experience, yes.
Wow.
However, there are some things I think that does help. So we used to have to graph our vital signs in intensive care. I worked a lot of years in the coronary care unit and CVRU, the open heart recovery. And in the coronary care unit, we used to have to graph. Now, this is an example of where it actually improved my time. So in CCU, we did have to graph out our vital signs, and in intensive care, we document vital signs every 15 minutes on our patients. That's a lot. So you have to graph them out, and and we had to write them below because we had this flow sheet documentation tool that we used. Okay, when I transitioned from that particular facility and I came to a large level 1 trauma center, and believe it or not, this was actually in the 90s, I went into open heart recovery, and we did have an EHR for that particular unit. It wasn't the entire hospital, just our particular unit. And it actually, we did hemodynamic monitoring where the machine did our vital signs basically for us, and it would document that in the EHR every 15 minutes for us. That was an area where that improved my time, and it did give me time back to take care of my patients. So I think that not everything can be blanket stated that it increased our time. I think that where we first failed with the electronic health record implementations, where we had a lot of duplication of documentation, where nurses had to document here and here and here and here because it was like, well, we need it over here for this particular reason, or this particular provider wants it on this particular view. So as technology has improved, and as we have studied some of our populations and what some of the informatics nurse specialist role entails, is where we say, hey, this is a burden for your nurses. They are dying, having to document the blood sugar of a patient in 6 different places, and that's why they're missing it over here, because they're putting it all over in all these different places where you actually have where a glucometer that, or AccuCheck, whatever you want to call them, that you can take the person's blood sugar, and it can actually go through the cloud and document itself into the care record and put it in all those places you want it. So that's called optimization. So in the beginning, you had the nurse doing all this data entry, and then through optimization projects, you can actually have it to where it will document it after he or she takes that blood sugar and automatically document it and put it in all of the different places that all of the different people who needs to see it can see it. So that is an example of an optimization project.
Yeah, that makes sense. That makes sense. And I was just curious. So I looked it up as well while we're talking here. And ChatGPT says, and you can tell me if it seems it's accurate or not, but that meaningful use refers to a set of standards established by the Centers for Medicare and Medicaid Services, so CMS, to promote the adoption and effective use of electronic health records by healthcare providers. So the goal was, okay, we're going to use these standards to get people off paper onto these EHRs, and then with the goal of improving patient care and enhancing healthcare efficiency and ensuring the secure exchange of health information, which I see because this is really interesting to me. But so my mom is going through treatment for pancreatic cancer right now. And one of the hospitals that she's going to, where the surgeon she sees is located, doesn't have, at least for the patient side of things, doesn't have like a patient portal. So all of her records are on paper, supposedly. And like when they're going to be sending them to the other hospital in the town she lives in, like they have to, I don't know how they get them over, if they fax them or what they're doing. But I was kind of shocked that was still a thing. And I was like, oh, I definitely, from the patient side of things, see the benefit of having my chart. And it's like, I can log into my chart and read my test results, and you can communicate these to all my different providers because, I've got, especially in cancer treatment, you've got so many providers and they might be geographically separated as well. It's like, okay, well, yeah, there's a real advantage there. My other question that I was thinking about earlier related to your study, when you mentioned that you collected the data in 21 and 22, right?
Mm-hmm.
Was there ever any kind of concern as to, are these, and I know that we're looking for correlation and not causation here, but is there any concern as to whether like this sentiment of cognitive load, or this, maybe not just sentiment, but this actual cognitive load increase was a result of doing the study in the time of COVID?
You could have factors associated with that. And actually, I did have to change the studies, how I was going to conduct the study, because originally it was going to be at a large healthcare system, but they decided that they did not want their nurses to have any extra burden, which would be survey burden. And so I changed that to going through the Emergency Nurses Association, which I think actually made this study better and more, it was richer, it was nationally versus regional. And so it could have, I can't say that it did or did not from a statistical standpoint, because that was not an analysis that we did. Now, if you do like things like longitudinal regression, you can sometimes get into, what were those type of factors. The couple of other things you had asked that I did not answer. One of the things that it did take probably 9 months to a year to conduct that one study. I'm still in the process of I have the article for the psychometric measurement under review from a journal currently. And so I'm still in the process of publishing, because it is a tedious process of all of that. But I did publish the literature review, the concept analysis, the theory, how the theory was selected, because we utilized a theory to frame the study, which is SEEPS, which is a patient safety theoretical framework and or conceptual framework. And then, so there's been a lot of publications that's come out of it, like the one in October, and then I'm still in the process of that. So that when you're doing a large research study, it does take time. And I think that is another reason why we are still in the baby stages. The legislation that meaningful use is associated with is called the High-Tech Act, if anybody wants to look that up. And it's kind of older legislation. Things have kind of moved on since those days. And I was trying to remember if there was something else that I may not have answered, but I can't remember. You probably remember.
No, I don't know. That's okay. Well, I always think I forget stuff all the time because so many questions pop into my head. And it's like, well, yeah, right. Yeah. Cognitive load. It's like, if it was important, it'll come back. And if not,
Right.
that's it. That's, the luxury I have, like recording a podcast. Nobody is going to be, no one's safety is at risk if I miss a question. So,
Well, that's good. That's a good thing, right?
right. Right. There are a couple of things I definitely want to focus on, though, to take advantage of our time, because you've got a really unique perspective, both as an educator and as a past president of the American Nursing Informatics Association, right? So I want to take advantage of that here by thinking, or just sort of starting to explore, in ENEA, you probably have had the opportunity to interact with a lot of other leaders in informatics, right? When in your conversations, I've got to imagine this comes up, but do you guys talk about the biggest hiring challenges that you face in informatics, or what other leaders are facing, and how they find the right talent to meet those needs? Because like we talked about earlier, there's often not a super clear pathway to getting into informatics.
Mhm.
Right. So, but I've heard from other leaders, there's really, really high interest. So it's like on one hand, you've got very high interest, but maybe not a super clear pathway to get in. So yeah, from like what kind of challenges does that sort of dynamic result in for hiring managers or for leaders?
So I think there's a number of things. First of all, this is not, new news that we are in a nursing shortage. And when you're in a nursing shortage, you're in a nursing shortage from all specialties. So informatics, I do believe we are in a shortage of informatics nurses. And I think that there's some other extenuating circumstances when you're thinking about informatics specifically. A lot of people, and even within our own nursing profession, and within healthcare, within the nursing profession, and then definitely within the public, people do not even know what an informatics nurse specialist is, or what they do, or any of those type of things. And so a lot, as an educator, what I see is a lot of your nurses, they navigate to those traditional, when you go into graduate school, they navigate back to what they know in those traditional roles, such as nurse practitioner, certified registered nurse anesthetist, some of those more traditional things that they associate graduate school with if they do decide to return to school. Leadership is another one that I often see. Even your nurse leaders in practice, frequently they do not understand the role of an informatics nurse, how an informatics nurse can greatly and significantly improve and impact patient care outcomes, because really our role is unique, and it's a really broad, nursing informatics is very broad. So then it kind of funnels down to like what I call nursing informatics subspecialties, or subspecialty type of roles. So like, for instance, I'm certified as an informatics nurse through the ANCC, but I'm also a Six Sigma Green Belt. So that means I can take workflow and do like spaghetti diagrams, and, what is, should we move our supply closet to closer to where the patient care is taking place, because the nurse is walking 5 miles back and forth between the patient's room and the supply closet every shift or whatever. Those are some things that you can look at from a lean standpoint. From an informatics standpoint, you can plot out, what is that process within the back end process, within like the electronic health record or other tools that is not working proficiently or efficiently for the clinicians, such as, the glucometer that I talked about earlier. Is there a way that we can get it to auto populate those fields instead of somebody having to go in there and do and complete data entry? So those are things that you can do. The other thing that is heavy right now, especially in healthcare, is big data, data analytics, the data nurse scientist, informatics research, educators and education from not just the academic standpoint where I work, but also there is the role of the informatics nurse that does a lot of the training at those clinical sites. So they could be an informatics trainer and train your new employees on the electronic health record and their documentation when they're coming in, but also they will train whenever you're doing some type of optimization project or an upgrade, because you always have your upgrades where things are improving. So you have multiple roles or subspecialties that people could go into. So I think that there's just this disconnect in knowledge or understanding that it's very broad. You can become an informatics nurse. There's super users usually on every and you don't have to have a graduate degree to be a super user. You can just be any bedside nurse that's on that particular unit. Often they're the super user and they help others who may not know how to use the tools and instruments. They also help those trainers when you're rolling out the change for that change management of various new and upgrade things that's coming down the pike. So there's so many different roles. Now, I will say, if you look at the HIMSS Nursing Informatics Workforce Survey, which they collect this data, I think it's every 2 years, you will see the average informatics nurse salary, and you will see that it correlates the higher education you have. Like if you have that graduate level degree, you do have a higher salary. You do have more advanced opportunities for those informatics nurse specialist roles. And then in addition to that, if you're a certified informatics nurse, there's an association to a higher salary with that as well. There's association the more experience you have, because a lot of your more experienced informatics nurses, they go into the informatics nurse leader path, and they can be a manager, director, or even the chief nursing information officer, or even the chief information officer. I know of a number of nurses that hold that role, which your very top tier role of the entire department leadership wise. So there's different pathways. You can be a leader, you can be a data analyst, you can be a project manager, you can be a trainer. I mean, there are so many pathways. And it's just kind of like, what do you like? What do you want to do? It's not what Carolyn Harmon wants to do, because I'm doing what I want to do. But what do you, as a student or as a person that's interested in informatics, what do you want to do? So that's the conversations I have with my people or my potential students that contact me.
Yeah. And so not to oversimplify it, but it almost sounds like the initial challenge in hiring long-term even is coming back to just an awareness of, well, what are the different options out there? And maybe if we just had this, maybe again, oversimplification, but if we had an infographic that said, here's all the different areas of informatics, right? All the different possible roles. And then here are the different pathways mapped out as to how you get started. And also, I think that's really important. And I'm sure being an educator, you probably feel this way as well. Like, okay, if I start in this, where could this potentially lead me? Because if I'm about to embark on a 20, 30, 40 year plus journey, let me know before I start taking my first steps, even where is this ultimately going to take me? And then I can ask myself to try to make a better informed decision. Is that where I want to go? Is that where I see myself going in the future? And I know that, circumstances change and we make all kinds of different pivots throughout life. But if we at least can have an understanding of what it might look like. I mean, like in business, people are like, oh, if I get started in this role, like here are the traditional roles in a business that I could move up into. Like I know what C-suite looks like. Okay, is that where I want to be in the future? Right. But there's seems to be some ambiguity with informatics.
There is, and then also there's ambiguity associated with titles. So one institution may call it a systems analyst. Another institution may call it a clinical informatics specialist. And I mean, there's just different titling of what these roles are. And then there's the quality aspect, the outcomes manager and the all of those people who are doing optimization of processes and data analytics. From a quality standpoint, you have many of those roles are considered informatics as well.
Wow. So maybe, and this is probably a result or a symptom of the field being newer compared to traditional roles in healthcare, right? So either there's maybe some standardization that happens over time or needs to, or maybe even in that visualization where you're laying out the different roles and the different pathways in each little bubble, if you will, it's like, here are equivalent titles. You might hear it called this, this, and this, right?
Right. And each system is a little bit different because like you have like your huge systems where they're layered with like you have the manager, the director, you have actually this whole pathway of leadership in informatics where like some of your smaller little standalone hospitals or your outpatient or public health, they may have just one person in a leadership position, and then you have your informatics people that fall under that. Also, the other thing that I think could be a disconnect is because a lot of the roles are kind of behind the scenes, especially through COVID. They found out that why are we bringing people in to sit in these offices and paying all this, all of this money for these office suites that we really don't need, that people can do. So a lot of these nurses work remotely and they're not often seen, or even if they're in offices, they're not seen as much in that clinical at that bedside, but periodically. So it just depends also again on the role. So if you're doing a lot of data analytics on the back end and just spitting out reports and those type of things, you're probably not having a lot of interaction with the bedside nurse or physician or respiratory therapist, physical therapist, any other people or members of the care team.
Yeah. Wow. That totally makes sense, that lack of visibility. So out of curiosity, just in general, generally speaking, how do salaries in informatics compare to like nursing salaries?
They're much larger.
Right. So
because it's a skill set that's unique.
Right. Absolutely. And being obviously like in informatics recruiting, I'm aware of this, but I want other people who are just kind of listening and they're curious about like, well, what does it look like to transition to informatics? The thing that drew me to it was I feel like it's not going to be for everyone, right? You've got to have the right aptitudes for this and like that love for technology and data and workflows and problem solving and all these things. But if for the right person with the right mix of personality and aptitudes, it's a great opportunity because of a couple of things you just said. There's a lot of flexibility in the opportunity to work remote or hybrid. And there's also larger salary options, which I feel like a lot of people in healthcare who are experiencing burnout, and they're like, well, what the heck am I going to go do now? Because I've got a very specific background and I get paid pretty well. So how am I even going to go make this salary doing something else without having to go back for extensive, unrelated education?
So it's interesting that you say this because a lot of nurses are feeling burnout, and through the HIMSS workforce study, it does tell us that the informatics nurses are reporting much more higher levels of happiness, joy, and satisfaction, and less burnout. But it depends on your role. Like, for instance, if you're doing a lot of support, and sometimes that's your entry level role, that can kind of bear on you. But once you get some of that experience, you can move on to other things. You don't always have to have that. And then sometimes you can land a position that you don't have to start with the support level, where you're doing like a lot of break fix, where like maybe somebody can't get logged in and stuff like that, because the clinicians have to be able to do their jobs, and they can't do their jobs if they can't log into the tools. And so that's a support role. But so some of the more advanced roles that most informatics nurses like seem to be the data analytics, the project management, even your systems analyst, where you're looking at workflows and those types of things. And again, the Six Sigma roles and the quality roles. I mean, some of those more advanced roles where you really feel like you're using both your skills, which is your not just your technology and data skills, but you have that clinical process and understanding of how to care for people and care for patients, and how a care team operates and works. That's something that we bring to the table that very few people who are heavy in technology, they just don't have that skill or understanding of the care of that patient and those bedsides. So it's advantageous to have. Sometimes the role is just being a liaison between the two, because you have two camps that they really have difficulty talking to each other. So if you have that liaison person who understands both camps, that's really good, especially in your project management, because that's how you really can roll out successful projects. I will say that, so you have the joy, like I said, the burnout and stuff like that, but also that survey does provide salaries and stuff like that. The informatics leadership salaries are quite significantly high. So that's a pathway. If you are intentional and you really want to make very good money, it is through that pathway. And I don't know of any other pathways of any higher salaries that can go along those lines. I mean, there are good salaries with other graduate level degrees, but a master's degree that can take you to deep into the 6 digits and close to 7 is through that informatics leadership pathway. And now that is if you do have that 30 years, if you're going to, because you do have to, you have to start off just like everything else, start off kind of on the lower end and gradually go up. Now, sometimes if you have a historical like leadership experience and those kind of things in your CV, and then you develop those informatics skills, you may go through that pathway faster. So there are different situations of where somebody could rapidly go through the pathway. It's
amazing though, just because I feel like for so many reasons, for people in nursing that are looking at this like, man, there's a real physical demand on my body and caring for my patients. I don't know that I'm going to be able to do this into my 60s, right? Like, oh, wow, maybe I could leverage this and my interest in technology and my clinical background to keep making a positive impact on health outcomes, improving patient outcomes, and it's sustainable. I can continue to do this and I can make even better money. Like, what a win all around. That's amazing. I think also that so I've heard the term, liaison used a lot. I've also heard translator used a lot, translating between the technical and the clinical side. But it just makes sense that nurses would be so great at it because you'd have so much empathy for your most frequent end user. It's like, oh, well, when I was a nurse, this was really challenging for me. So if I'm designing new workflows, this is how I'll do it, how I would do it with them in mind, because you can understand how you used it and how they're going to be using it. So I think that's really, really amazing.
And nurses get into healthcare. I mean, all healthcare care team members, no matter who you are. I think you get into it because you want to help people. And some of the most rewarding things for me along my pathway has been, I have projects where all of my projects had to have like return on investment data points. And most of those go back to outcomes. And when you can take, like, for instance, I took one hospital facility from like the 65th, 68th percentile in core measures, which is surgical care, pneumonia, heart failure, heart attacks, those metrics, to like the 95th, 98th, and then, other things like that. That's very rewarding, and you feel good about what you're doing because you're touching people's lives, you're improving lives, because we know that when somebody hits the door and they're having chest pain, if we give them an aspirin, that it improves their chances of living, or their mortality. It improves mortality rates. We have evidence from heavy long-term research over the years that informs us of this. So when you're doing those type of metrics and processes and whatever, in using tools in technology to leverage and improve those type of things, you feel really good about that. And then if you can take it one step further and take outcomes and connect that to dollars, then you have a seat at the table where you get a voice, and you have the attention of the decision makers, which is usually your executive team that's at the top of the healthcare system or facility, or whether you're in public health, whatever, you get those people's attention, because dollars really is how you can get a seat at the table and you can get people's attention. That just seems to always be where I have found success.
Yeah, that makes a lot of sense. Help me understand, see if I understand this correctly. So those core measures,
Mm-hmm.
when the system you're a part of went from the 68th percentile to the 95th, is that what you said, 95th or 98th? What was your role in the organization when you were helping do that?
My actual title was outcomes manager,
Okay.
and I did a heavy data analytics, root cause analysis,
So it was
drill
informatics related, though.
improvement. Yes. So it's all informatics. If you're doing data analytics, process improvement, workflow analysis, automation, leveraging technology, working with programmers over in the technology department to maybe build algorithms on the back end of something, so that you can have what's called clinical decision support that I discussed earlier, and you have those like maybe pop-ups or automated. Maybe it's informing your team that hey, this person didn't have their pneumonia vaccine, they meet all the qualifying criteria, and they need to have this vaccination before they leave the facility. I mean, those type of things, whatever it is that you can do on this algorithm. One of the big things that I did, now this wasn't core measures. Now, core measures was really important in the fact that I don't know if they're still back then it was publicly reported and it was on the internet. So you could look up and do a comparison of each facility to see who was doing the better in these metrics. And that helps empower the public in making the decisions on what facilities they want to choose. What facilities they may want to choose to go to. Because if you have Medicare or Medicaid, you pretty much can go anywhere you want, to go. Yeah, so, sure. Of course, I'm going to go and I'm going to guide my family to go to somewhere that I know has the better outcomes. And that's just something I'm going to do. And it's interesting sometimes to go out there. Sometimes you think that this particular place is the place to go to. But then when you go out there and you look at their performing metrics, you're like, oh, that's not so great.
Yeah.
And so you're doing a lot of different work. You may have these odd titles, but you are working with informatics teams. You're working with programmers. You're working with the care team. You're improving processes. You're looking at data metrics. You're drilling down to root cause to see, okay, why is it that we're missing these particular, and sometimes you're looking at specific patient medical records and seeing, you get down to even the individual, like which patient was this a miss on and why? Where was this patient at in the facility? Who was the people caring for the patient? I mean, those kind of things. Sometimes it's as easy as having conversations with those people. Hey, did you know that this is the evidence that this is evidence-based practice and this is what we need to be doing? I mean, sometimes it's as simple as that, as education, but most often, it's not education is not the key or the factor. It's systems failure. If you look at Redonda, the lady that was in Tennessee that made the medication mistake, there was multiple reasons and multiple factors that was involved, and it wasn't just that she wasn't aware of the medication and she was so busy that she did not look up the medication. It was also a systems failure. Why was she able to get her hands on that medication? I mean, just like the problem with the nurse that gave the succinylcholine that I was talking about. Why was she able to get her hands on that? usually your CRNA, which is your anesthesiologist, should be the only people that has their hands on that. Sometimes your emergency department physicians, yes, because they may have to intubate somebody, but out in the emergency department. But why was this particular nurse able, when she was trying to get cardiazem, which is for a cardiac arrhythmia, why was she able to get her hands on? And this was through an entire electronic system, through the Pyxis, which is a Medicaid where you go in and you access your medications, and it's an electronic system, and so there are systems failures, and 9 times out of 10 there is some type of a system failure that you can improve, that you can prevent this from happening to the next person.
Wow, that is so key, right, for a number of reasons. But if we look at it from, yes, it's amazing to have improve patient safety and better outcomes, right? We're all consumers of healthcare. We all want better healthcare. But when you're looking at it from a career satisfaction standpoint, when you can go in and you can produce tangible outcomes, like, hey, this is what I did. I have something to show for my efforts today. It feels so much better, right? I mean, it's amazing.
Yeah, how great I felt to go. So within 2 to 3 years, I was able to take an entire institution from the 60 something to the 98th. And I was the only person working on this.
That's crazy.
Institution. And it was just using my knowledge, skills, drive, and motivation, because let's go back to why I became a nurse. Because I did not want anybody else to experience what my family had experienced.
How many patients come through that facility roughly annually?
It is in I'll just tell you where it's located, because the volume is going to be so high. I have right now no idea. It is in a urban downtown city in the Southeast.
Right. So you like that
tons. And
so many people.
It's a mixture. So it is, because we don't care, and people think that people in healthcare, that we are always looking at insurances, and we don't. I mean, I never looked at my patients' insurances. I mean, and I worked the emergency department for years. What I did is I took care of my patient. I took care of what they brought me. So if EMS brought me this person, I don't care if they're insured or not. That's on the accounting department end. Let they take care of that. I'm going to do the best that I can to take care of my patient that is in front of. I mean, we don't have time to even look that stuff up, and it's so interesting because people really believe that we do. And I mean, I couldn't tell you, but I do know that because I did do case management for that same facility, which is helping people with their discharge. And when you help with people with their discharge, and you're getting, like, let's say, wheelchairs or whatever for them to take home, you do have to know what their insurance is, because then you have to attach that to whatever durable medical equipment, blah, 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 that you're going to use. So I do know that it was a mixture. We had some people who had regular insurance. We had Medicare, Medicaid, and then we had people with none. I mean, and we had and we also had, especially when you're doing discharge planning, you are heavily involved with your homeless population. And we had homeless. We had a homeless population that we cared for. But you want to do a safe discharge. That is our responsibility, and we're held accountable to do that. So that is, so I do know that it is a mixture and of the population, and that we have high volume.
Yeah. So that was kind of my heart behind that question. Like, just thinking about the tangible impact you made in a high volume facility going from the 60s to the 90s. That's huge. So now I have to ask this: when you had opportunity to make such a tangible impact, what was it that spurred you to shift into the educational side of things, right? So you're professor and director of healthcare leadership, nursing informatics, and nursing education at the University of South Carolina. So yeah, what was it that prompted you to make that shift? And then, like, what are you actually doing these days, like, in your role? What does that mean?
So, so I worked heavily on the quality side, and then I also worked heavily on the informatics IT side. So I actually did do, so a lot of how can I say this? Uh, Roles, and I had climbed the ladder, and I was in the C-suite, and I was working. I reported directly to the CEO, and it was a for-profit in a rural town. I had transitioned into this type of role, and it was very stressful because everything was heavily associated to that for-profit model. And then in the C-suite, it's just a lot more pressure. And I did start feeling a burnout. And I had just completed my first doctoral degree. I have 2 doctorate degrees. I have a doctor of nursing practice with a focus in executive leadership from the University of Alabama at Birmingham, and then which is a DMP. And then I have my PhD that is focused in nursing science, research, data analytics, all of those things. And that is from the University of South Carolina. So when I was during those days, I was thinking, okay, I now have these this particular, because it was my first doctorate, this particular doctorate degree, and what do I want to do? What brings me joy? Because I'm starting to feel the burn. And I will say that's not uncommon when you work in the C-suite, and it's unusual for people to be in the C-suite for many, many years. Some people do that, but there's others that we do it for a handful of years and we move on. And that was me. So I did a lot of middle leadership in healthcare, and then I did the C-suite for probably about 3 to 5 years, something like that. So I decided to move on, and I was trying to find my joy, but I had been teaching on the side for many years. And one of the reasons, what got me into that was I was the first certified informatics nurse for Atrium Health out of Charlotte, North Carolina, which is a large healthcare system, and they actually own a couple of little colleges, and their RN to BSN program had asked me to teach their informatics course, and I taught that, and then I really liked it, so I started teaching for some other institutions as well, and I did that for probably, let's see here, about 5-6 years, while I was also probably because I was doing too much is why I started feeling the burn. I was in the C-suite, teaching on the side, and I was finishing and I was doing a doctorate degree, and so that, which is a lot, and so I decided at graduation, what am I going to do with this? So I decided to transition into academics full time because I really love teaching, and it brings me joy because I feel like I'm giving back. I feel like I'm starting to get older, and and I need to share my knowledge with that next generation, and how can I impact, because if you impact the next generation and future generations of nursing, then you have made a change for many years to come. Although I made a change in populations at the time that I was doing the population and those things in the C-suite and other places I was working, I felt like, okay, how can I make an impact that is for the future that's beyond my years that I have left?
Yeah, you're leaving a legacy.
Right. My legacy. I should say it that way instead of making me sound so old.
No, it's perfect. That's great. So, okay. So like from a day-to-day standpoint now, how are you interacting with students? You're teaching classes, you're in programs. What are you doing?
So I am in leadership. So I taught for, I think one academic year after I transitioned. I taught for one academic year, and where I was just, the professor teaching. And then I transitioned into, because people knew my background, I'm good with processes and operations. I do really have that good skill set where I can operate and make things work that other people don't really have a brain. Their brain just doesn't. I'm not saying they don't have a brain. I'm saying that
we're all just gifted uniquely. Yeah. We have different aptitudes for different reasons. So
Right. Exactly. So I actually have this way that I can look at things, lean it, make things work smoother, use less faculty resources, place more cohort of students together. And I'm also good at starting programs. I have also had accreditation and regulatory that reported to me in the healthcare arena. So when I transitioned into academic leadership, I did work for a number of years instituting new programs where you do get the regulatory and accreditation experience. So I have heavily that, which is a part of your operations. So not only is operations just your management of your students and your resources and your scheduling of courses and things like that, but it's also, your accreditation, your quality, that continuous quality improvement to make sure that your curriculum is, that you're building a curriculum that will impact and make those changes so that those students come out, that they're employable, and that they have this skill where they will do great things, where they will go into their practice and they will do great things with their practice that they have learned. So, and I also teach. So there are many aspects. When you're in academics, you have your scholarship, which is your research and your publications, your presentations. Then you have your service, which is your professional service, which is part of my I'm a past president of the American Nursing Informatics Association, and AKA ANIA. I do a lot of, I'm in a couple work groups with the Nursing Knowledge Big Data Science, where one is with advocacy and policy, where hopefully we can impact policy at the legislative level. And then the other is education, which is, how can we impact curriculum and teaching and education and training. That's part of my service. You also have your service to the public. I serve on a couple boards within my city that I live in, that I'm a resident of, so that I can impact and use my nursing knowledge and skills that way to help guide people with some decision making and with people with disabilities. And then, so you have your scholarship, your service, you have your teaching component. So I teach the leadership practicum and the informatics practicum, because I'm over the healthcare leadership program, the nursing informatics program, and the nursing education program. So you have, and then you have your professional part where you keep up with your continuing education. That's how you stay relevant in your knowledge about your practice and your specialties and those things. You have your licensure and your certifications and all of those things that you maintain. So it's really well-rounded, and I like the cognitive, the use of my brain in my job.
Yeah, absolutely. It's great. So you mentioned a goal of making your graduates employable, right? So what do you think, or what do you know to be the most important skill for somebody graduating from a program or entering the field of informatics?
So I think that it's not just what I think. So this is multifaceted. So how I view this is keeping up with the current and relevant, skills and what, research from literature reviews, and then also the continuing education. And a lot of our continuing education do come from our professional organizations such as ANIA. I received continuing education from HIMSS recently. That's another organization that is that's a healthcare informatics organization that's more general, that's not just nursing focused. ANIA is the only nursing informatics focused organization. So I do that, as well as, so just keeping up with, what is the current research, what is the current, education, what is the current technology. But also, I'm in the process of creating what I call an advisory board. So I will engage healthcare leaders as well as healthcare informatics. So that they can, I can report to them, here are my outcomes, here is the of the program or programs, and here is the way the curriculum is, because we do have the accreditation piece, and I'll talk about that in just a second. But what makes what kind of skills are you looking for to make our students relevant and employable? What are you seeking? What do you want? So that if you hire one of these graduates and these students, what will make you happy? We also do, so that's an advisory board where they can, review that data, talk to me like twice a year, 1 hour, whatever. Also, we survey our students while they're enrolled. We survey our students after graduation, and we survey out their employers, who employs them. So we look at a number of metrics there. And then through our accreditation body, which is the CCNE, which is one of the nursing academic specialty accreditation bodies, we have, they come in and we have data that we have to report, and we have to report to them, but they also come on site and do surveys. So there's a number, we do self-study surveys, there's a number of things. And then we also have a regulatory body in every state, and that's your Board of Nursing, and that's your licensure body. And they also have if they so choose, they can come in at any time and survey. And then we also know the Department of Ed, that's another regulatory body. They can do a survey if they so choose as well. So there's all things that we have to do, our continuous quality improvement, and make sure that we're collecting the data and making sure that we're relevant.
Yeah, absolutely. So what are graduates from this program? What degree are they coming out with?
So they have a master's of nursing in nursing informatics, and there's a number of skills that they're currently acquiring throughout the program, which I think is really innovative and is relevant to today. So you get the MS in Core. That's what the MS in Core is, what our accrediting body says that all master's degree nurses should have, regardless of the specialty. So regardless of whether they're becoming a nurse practitioner or a leader or an informatics nurse, they have to have this core group of courses. So everybody has that core group of courses. Then they go into their specialty courses. So our specialty courses at South Carolina offers finance. So they have a finance course that they are in with the leaders and with the leadership students, and they have an understanding of the way healthcare finances operations work, as well as how will they support those systems if they are if they do get a position that they have to support those systems. And then also if they're in a position of leadership, or even sometimes considered the subject matter expert, they may be included in the selection of a technology for an institution, which could be a multi-million-dollar decision. So you do need to be astute with your ability to understand finances from a selection standpoint. So they have a finance course. They also, we have them go over to this is online. It's an online program, but they take courses under the Health Information Technology division of the engineering college that is through the University of South Carolina. And in those particular courses, they're exposed to other like healthcare specialties, like this could be pharmacist or whatever that is getting a master's in health information technology. And they're in there in these courses with those individuals and working with others. They also so the two courses, one is a project management course, and the other one is where they have SQL coding training, where they have this skill that is very applicable when they transition to graduation and to their jobs. So then they also, the nursing informatics courses that we offer, we prepare them for if they want to become an informatics certified nurse. So we go through all of the criteria and information. So at the graduation point, they can actually sit for that certification exam if they so choose. They do not have to. This is not like a nurse practitioner program where you have to have that to practice. It's not like a licensure or any of that. It's just a certification, but they have the ability to do that. And we do collect that information if they choose to get that certification. So we do look at that to make sure that our students are passing and that we have that quality within the program as well. So it is, I think, a very well-rounded program. We're in the process of looking at a few other skill sets that we'll ask the advisory board, but we're incorporating today machine learning, artificial intelligence, some more data analytics, those kind of skills.
Wow. That's so much. How long does it take to go through this program?
Approximately 18 months.
And is that full time or while students are also still working?
Well, full time. You can go through the program what is considered full time and work full time at the same time.
Wow.
I've done all my degrees that way. So I started out as an associate degree nurse, did the RN to BSN, MSN, DNP, and PhD while I worked full time. So most nursing programs are set up. That's why it's online. That's why we work with the students when they do their practicum. We pair them with. We try to be as we pair them with who they want to, like, I talked about the subspecialties earlier, where, who do you want to work with? Who can give you, do you want to become that leadership pathway, the training pathway, the data analytics? So we try to pair them with the right pathway for whatever their career goals are. But also we try to provide them with that flexibility. They can do this at the institution that they work. If that institution has a contract, I mean, there is some legal things because of just the way operations are with, we have to make sure that we have a contract, which we can also acquire a contract if we know that there isn't one and we need to get one. So there's a number of things that we try to do for flexibility so that the person does not have to interfere with because we all know that adults have bills and lives and families and those kind of things. So we don't want to interrupt that, but we also want to make sure that we have a student that is relevant and employable.
For sure. So with it being online, are students able to join from pretty much any geographic area then?
Yes. So, but again, there is there's certain states that has certain legislation that, and this is the whole online, and it's called NC-SARA, that regulates this, no matter whether it's nursing or any other online degree. You need to, if you're a student that is looking at the possibility of coming to any institution within any state, you need to look at whether that particular institution aligns with your state of residency, and that's called NC-SARA. You can look that up. It's online, and you can see if the institution. But we have like tons of states that we accept students from, and that's all over the U.S.
Cool. That's awesome. So how do you measure success of a program like this?
So it goes back to those metrics that I was talking about. You have your accreditation. We have it. We also have all of our learning outcomes mapped to what's called the AACN Essentials. And those essentials go back to CCNE, which is our accrediting body. In addition to that, if you're looking at a specialty, we utilize, what does that specialty entity, what are their standards? So we also have everything mapped to those standards. So we have a map to the nursing informatics standards of practice. And then, we look at those survey, the feedback from the employers, from the students, the graduates, the alumni, and then, you don't have to create this advisory board. I just personally like that because I feel like this is just an added piece that where you have your leaders and you have your other informatics, just, making sure that you're staying relevant to practice, making sure that you are incorporating, because sometimes, your accreditation standards, they're great, but they may not encompass, and even your specialty standards, it may not encompass every little thing that that an employer is seeking for, or the expectations of what do our graduates, so you don't have that huge transition to practice barrier, so that's an easier way to get them, from the academic arena and into practice as soon as possible, and practicing independently as soon as possible.
Yeah, absolutely. This just makes me think of when I was doing college admissions consulting.
Yeah.
Parents would ask me all the time, hey, is X a good school? I'm like, that's a really broad question. Let's make it a little more specific. And is it a good school for what your child wants to do, right? Or for what this student wants to do career-wise? So what I found was an economist I think he was working at some sort of independent think tank, and he collected data on the return on investment of college programs, comparing the average cost of attendance with the average salary of graduates from the program over the trajectory of their careers, right? And I don't know if a lot of this had to do with forecasting, because again, like the salary data showed from like when they graduated until when they retired, basically. And the data was for 30,000 or 35,000 programs across the US, right? So I could literally objectively help a student make a decision saying, hey, you're going to get a better bang for your buck, better ROI on a computer science program at this school over that one, just based on the average salary of your graduates. Having someone conduct that kind of a survey too, I think, because I think that this person, initially the data existed for undergrad programs only, then they expanded them to master's programs as well. But I love data like that, and I'm sure people in informatics do too, right? You're wired that way already. But to help students or professionals who are looking at, okay, where do I want to go in informatics? Well, that really is useful, because you can say, okay, well, what kind of income is this probably going to yield? What's my life going to look like? And then what are the best programs to get me there? Because I mean, I had students even getting as granular as like, do I want to do mechanical or electrical engineering? Do I want to do computer science or computer engineering? And you could literally look at the numbers of the average salary data for all these things. And I just feel like that's so beneficial. But you mentioned something a little bit ago about machine learning. And I think this is such a hot topic right now. I would love to hear your take on this. How do you envision the integration of artificial intelligence and machine learning in informatics, and like what is to come in that arena?
So I do believe, so this has been a hot topic this year and last year at a lot of our conferences through ANIA, and then also it was at HIMSS, and it was at the Nursing Knowledge Big Data Science. So if you think about it, machine learning is basically where you, and the more data you have, or the bigger, big data is really key here. That's what machine learning comes from big data. And then, so does your artificial intelligence. So so this is what I think, especially, if you look at ChatGPT, let's use that as an example. There's mistakes sometimes that it makes. So for instance, I will type something in and ask a question, and then I'll say, provide me the evidence-based literature or articles that supports what you just told me. And it'll give me, especially I named names earlier in my particular specialty of people who are the researchers or the founding researchers of the areas that I have interest in. So sometimes I have that knowledge already. Sometimes I don't, but it depends on the topic. But I'm like, oh, that's so wrong. Or I go to try to find that particular article and I can't find it anywhere. So I know that there's mistakes. So there has to be some checks and balances. With that being said, I have been asked the question, why are you still sending your students to SQL training? Because is it not going to go away? Well, I think that you need to have that foundational knowledge so that you can check behind the checks and balances of, and it's not gone away in healthcare right now. You still need that skill set. If you're going into data analytics, you need that skill set today. That is heavily needed. Okay. Futuristically, I think that in the beginning, it's just like anything else. We are going to need to have those checks and balances in place to make sure that it is doing the appropriate and correct analysis and that it's spitting out that information. Where I think we can go is I think that this could be very heavily supportive for especially that bedside nurse or physician or whoever is caring for the patient, because I think it can be I think artificial intelligence can be heavily supportive. Do I think it can take away positions? I don't have that answer. Possibly, but today, right now, no, it cannot, because you do need the checks and balances. And also, you know, there's certain things that a human being has, especially when you're thinking about healthcare, that a machine does not have. And that is empathy and touch and caring. Those caring moments that you have with your patients, you can't take that away. That's a human to human connection, human to human touch, and empathy, and wanting to do and improve and care for people. Those things, I just can't see a machine or a robot taking that away. But I may be wrong. I mean, maybe we have intelligence that advances so much that it can get that. It can. But today, I just don't see that. At least for the next 10 years, probably. And again, I will say that technology is at a rapid fire pace. So my hope is that we can make improvements, advancement, better decisions, better outcomes, advance the lifespan of human beings. That is my hope, and lifespan of human beings in a manner where not that where they have a better life, not
not just longer, but longer and higher quality.
Yes, higher quality life. That's what my hope is. So that is my take. Now, I think that there's still a lot to be thought about, and we need to do it intentional, because again, you know, when you look at some of the things that we're using today with AI, is it correct? Is it giving us the correct output? We have so many checks and balances that we need to go back to. It's just like any type of data and data reporting, you need to test it. Any type of project management in healthcare systems, technology, you need to have a test phase where you're testing out that this, before it touches a patient, you need to make sure that there isn't some kind of a mistake that can be made that can impact a life and have another sentinel event occur. I mean, because one sentinel event is one too many.
For sure. Absolutely. Wow, that's super good. So I know we're coming to the end of our time here. We've talked about so many different things. Was there anything else you wanted to talk about that we didn't touch on yet today?
Let me just run through really quickly. I just think that let's see here. Let me just double check.
Yeah.
To make sure, because I think that it's really important that people have an understanding of what nursing informatics is and how it can advance your institution, and how it can improve your care, it can improve your efficiency, it can improve your bottom line. because there is return on investment for the projects and the leadership that you can acquire from an informatics nurse specialist. I think that there is a gap in knowledge from a lot of operational and executive leaders. I think that there is also another gap that I frequently see, and you may or may not hear this, and that is for nursing to have a seat at the table. And I think that goes back to a lot of times we fail to use data to prove our points in nursing, and we need to start using, just take the emotion out of it and use the data, and so that people will listen to us and give us a seat at the table, so that they don't just think that we're whining or complaining or something along those lines, because you hear a lot about nurse burnout and a lot about this and that, and not all nurses are about their salaries. I actually, when I transitioned from the C-suite to academics, I mean, there's not salary parity between clinical positions and academic positions. Although, the government is trying to work on that through some legislation. It hasn't been passed, but there is not parity there. So sometimes people make those transitions because they feel better about what they're doing. And nurses need to have that joy, and they want to feel good about what they're doing. So do physicians and other care team members. My point of it is if you look at sometimes other people who have a seat at the table, such as physicians, they often take the emotion out of it and they talk data. They speak from, okay, if you hire us, we can make sure that we can change your, like an example of one of the projects I did. I moved length of stay in palliative care from 14 days to a 5 to 7 day length of stay. That is money, because when you know about diagnosis related groupings and how a institution is paid, you know that a lower length of stay brings in income. Those are things that an informatics nurse specialist can bring to the table. But if we can't articulate that and put it down to where, what I call the bean counters, where they can understand it, we often aren't heard. So that's something that I think is really, really highly important, is to understand what an informatics nurse does, what they can bring to your institution, and that it's not a role that you need to be very intentional about how, developing that department and developing those roles. And then also having that seat at the table for our profession. I think that's where we often have a failure, and that's generic. That's not just informatics. That's generic for the entire nursing profession. And I don't know if you ever hear that.
Oh, totally. Absolutely. You're probably at least the third or fourth person that I've heard talk about, seat at the table. And it makes sense, because if you're the people who are not only most hands-on with the EMR or the EHR, but most hands-on directly caring for the patients, it seems like that would be pretty valuable to be basing your decision-making around, right? Like that level of experience and that care.
Right. So, and I think that as time goes on, I have actually seen this improve throughout my career. We're listened to a little bit more, but I think that if we can just continually work on that and improve that and be intentional as a profession, and then that's how I think that our workforce will grow, and maybe we can get out of the shortage that we have been seeing. And this is not new. We've been in a nursing shortage since probably the 1940s.
Wow, that's so crazy. And I wonder too, because I feel like sometimes people will look at informatics as another competitor for nursing talent, but I wonder how informatics could be used to reduce burnout. So it actually increases that nursing retention because the people that are using the EHR, the EMR the most are happier doing it because it's designed in a way that reduces that cognitive load we discussed earlier. So then if you've got your nurses sticking through that 2 to 4 year point whenever people tend to leave an organization, and it's because of the way they interact with technology that's making their job easier, right? That they can actually spend more time caring for their patients. If we can figure out how to make that happen, then that's going to help alleviate that shortage, right? It's not just how do we get more people into nursing training programs and nursing education programs, but how do we first, plug that massive leak so that people stay? They want to stay.
Well, and then another project that recently was highlighted by NIA that was presented during one of our continuing education units is webinars. Was where an informatics nurse led a project where nurses who, because they physically could not remain at the bedside because, of their age or some kind of
demanding. It's physically demanding.
Right. It is a physically demanding job, but they still had their cognitive functions and their knowledge that they could contribute. So what they did is it's kind of like a form of telehealth where these intensive care units hired the nurses who had lots of experience. They were older and they couldn't physically do the jobs anymore. And they actually were monitoring these patients remotely and helping the newer novice nurses with saying, hey, have you looked at this person's lab values and coaching them to call the physician, just coaching them with the care management of that particular patient. And it was attached to outcomes and all of these different things. And also kind of like a mentor, a continuous mentorship for your novice nurses. And, just to kind of grow them into your more mature, advanced, experienced nurses so that they, could do think in this realm, but also, having two people looking at a record and looking at a patient at one time, even though it was all virtual, and you can still see, skin color and things like that, and you're monitoring, other like data and vitals and things like that. So it's really been interesting, that particular project of how that helped that particular institution who had complete turnover and had basically all new nurses, especially on night shift. And they just hired these virtual nurses to help support and advance their knowledge and guide them. And it was on night shift and they were willing to do that. So there are models out there that are creative and innovative that stems from what nursing informatics can bring to the table.
That's amazing. I love that. It's something that makes so much sense, but I've never heard of before. And I think that's so neat and very valuable, clearly. Carolyn, if anybody listening wanted to, keep up with your work and what you've got going on, is there a place that they can find you online or find information on that?
Oh, definitely. I am. You can find my faculty profile through the University of South Carolina. It has my email address. My office phone number is there, but I do respond a little bit quicker to email, believe it or not, because I am in and out of my office. And if there's any questions or if they have any interest, or even, one of the things that I think that if you have an interest in nursing informatics, you should definitely speak to someone like me and us explain informatics to you so that you can determine, should I do leadership? Should I do informatics? Should I become a nurse practitioner? I mean, what role should I go into? I'm ready for my specialty. I've been doing general professional nursing for X amount of years or whatever. And, what are my next steps? And I love and I welcome those conversations. I also, it's not just, at the master's level and specialty, but also I have that ability to understand the difference between the DNP and the PhD in nursing. And that's a whole nother conversation for another day. But a lot of times people, they misunderstand the differences and they'll they'll go in and actually get a degree in one of those or the other that isn't exactly what they want to do. So I like to have conversations with people so that I can help guide them about what they want to do. I'm not going to interfere with what I do, because what I do is what I want to do. And again, let's talk about what you want to do.
Yeah, that's so good. I mean, and even if it wasn't necessarily a conversation with you, just it's so helpful in general if you're considering getting into something. Find somebody. I mean, and with
Right.
the internet and LinkedIn and the resources we have, like find somebody who does that thing and go talk to them about it. Like, what do you actually do on a daily basis? What do you like about it? What do you wish were different? How did you get to where you're at? And yeah, so you can make a more well-informed decision. I love that.
And definitely look at things like workforce surveys, and that's kind of good informed knowledge. And I mean, just again, I go back to the data, making your decisions with
Well, for
data.
sure, because you want to get into something that's going to still have a high demand, so you have a likelihood of finding a role, right? And hey, use the salary data to shape your decision, because if it comes down to a couple different positions, I mean, life costs money. That's a real consideration.
It does. I mean, there is, especially, there's, if you leave the profession, it's like you're starting all over, and you may have to get another bachelor's. And federal financial aid, one of the things that they won't pay for, but however much dollars you spent, that's left over at that level. So you usually need to go to the next level of a degree. So if you already have a bachelor's, then you need to go to a next level. So leaving the profession is not advantageous, and it's not going to help the profession continue to advance either. And that's what we really need.
Yeah, for sure. That's awesome. Well, Carolyn, thank you so much for your time today and all the insight. I just love all the unique experience that you've had. So it was super interesting. Yeah, very inspiring too. To our listeners, we'd love to hear your thoughts and experiences on this episode. You can share your comments on LinkedIn or directly on the podcast website at pivotal.buzzsprout.com. And if you know somebody in healthcare or even not in healthcare who'd find this episode inspiring or beneficial, please share it with them directly. They can listen live on LinkedIn or anywhere you get your podcasts. Stay tuned for more episodes here on the Pivotal Podcast.